Okay, hello, welcome to this ICS webinar. My name is Desiree Vrijens. I'm a member of the Neurourology Promotion Committee and I work as a urologist in Maastricht in the Netherlands. And I want to thank the ICS for the opportunity for this live session. And I'm very pleased to collaborate with Dr. Hervé today. Would you please introduce yourself?
Thank you, Desiree. Hello, everybody. My name is Francois Hervé. I'm a urologist and I work in Belgium. I work in the Clinique Universitaire Saint-Luc in Brussels. And I'm also a member of Ghent University Hospital. It's a great pleasure and an honor for me to talk in this live session. And I would like to thank the ICS for the kind invitation and also for the great idea for tuning live presentation and scientific content during the strange time we're now facing.
Okay, and this webinar consists of two parts. First, I'm going to tell something about the relation between anxiety and depression and overactive bladder with a link to the current pandemic, corona pandemic. And next is Francois. Francois, could you shortly tell us something about your presentation?
Oh yes, in the second part of this session, we'll have together a view on different perspectives on Nocturia, not only from a urological point of view, but also from other angles. We'll evaluate together to which extent the lockdown and the work from home situation may have an impact on Nocturia.
Okay, so we're going to start the presentation. Is it okay? Okay, so the first presentation is about anxiety and depression and overactive bladder. And after the two presentations, there is some time for discussion. And if you are an ICS member, you can leave a question through the internet. So these are my disclosures. We're going to talk about, we've got a short introduction. Then we'll talk about the relationship between psychological comorbidities and overactive bladder. Next, we're going to say something about the common pathways, about this relationship, some practical points of view, and then we'll continue with the treatment of overactive bladder and affective symptoms and end with the take-home messages. So what about the COVID-19 and the bladder? As far as I know, there is no direct relationship between the COVID-19 and the bladder. I didn't find any literature about that. Nevertheless, I think that there is a relation between COVID and the bladder, but not through a direct relation, but with a relation with the psychological. So what's known about the COVID and psychological? It gives psychological distress. And there is a study done in Italy at the height of the corona that almost 40%, had psychological distress. And that patients of people with a negative inbox, people who looked at it, the glass half empty, they had more psychological distress. And also a recent reported literature systematic review reported in the Lancet showed that containment led to more post-traumatic stress syndrome, which is also confirmed by a Chinese study. So what do we know about the bladder? So post-traumatic stress symptoms and the bladder symptoms. This Bradley had done a few researches in female veterans, and it was shown that when they had post-traumatic stress syndrome or anxiety, that they were twofold more likely to get overactive bladder 1 year later. The evidence regarding the association between overactive bladder and affective symptoms is much higher. There is a systematic review done with 37 studies using only validated instruments to measure either the overactive bladder or the affective symptoms, so the anxiety and depression, with over 80,000 people. And they found that there was a bidirectional relationship between overactive bladder and anxiety and depression. So there is a real association. The evidence regarding overactive bladder first and then later in time affective symptoms is larger than the other way around. So how is the relation? Is it because of overactive bladder, you are anxious to lose urine, you have to find toilets all the time, and you may stay at home, social isolation, and therefore you get anxiety and depression symptoms? Or is it the other way around? You get anxiety and depression symptoms first, and later on in time, overactive bladder. As said, it has been shown to be both. But maybe there are common pathways, different common pathways, which can explain as well the overactive bladder as the anxiety and the depression. And in the next minutes, I'm going to show you some possible common pathways to explain these relationships. First, I'm going to talk about some brain areas which are important in avoiding overactive bladder and affective symptoms. Next, serotonin, norepinephrine, these neurotransmitters, and we're going to talk about stress, the APH axis. In addition to those, there are some recent studies that vitamin D and rho kinase may play a role as a common denominator for both, but due to the time limitations, I've left those out of the presentation. So what brain area should we look at? The insula, which is important in registration of visual sensations, so the registration of urgency, for example, but it's also very important in anxiety and depression. And then the limbic system, which is very important in primary emotions like fear and anxiety, but has also a role in the voiding cycles. We don't know exactly what it is, but it's probably with the unconscious monitoring of the bladder fullness. Then the anterior cingulate cortex, which is activated during bladder filling, but it's also increased activity in anxiety and depression. So another interesting part of the brain to look at in a relation to overactive bladder and anxiety and depression is the caudate nucleus, which is found in the sulcus, and it's important in the rewarding and the reward processing and in depression. The function in voiding is not 100% clear, but it's thought that this is activated during the initiation of voiding. So this study had 26 patients with overactive bladder and 26 healthy controls. And they found that patients with overactive bladder had higher anxiety and depression scores. And when they looked at the functional connectivity strength in the caudate, they saw that there was a negative correlation between depression and dysfunctional connectivity strength in the caudate. What this means exactly still has to be elucidated, but it's interesting to follow for future. Next, in addition to different brain areas, one can look for the neurotransmitters. We all know that serotonin depletion can lead to anxiety and depression, and that an SSRI, selective serotonin reuptake inhibitors, which restores the depletion of serotonin, is a well-established treatment for anxiety and the bladder, for anxiety and depression. But what do we know about the bladder and serotonin? There are some different models in rats and in cats, and when lowering the serotonin level, one could see that there was increased diffuser overactivity and increased voiding frequency. So things which resembles overactive bladder. There is not a real animal model of overactive bladder because urgency, one of the most important part of overactive bladder, cannot be reproduced in animals. But anyway, lowering the serotonin level increased diffuser activity and increased voiding frequency, but also the other way around. This is another interesting study which is done in female rats with a depression-like behavior. And this depression-like behavior, you could see that on the forced swim test. They were less active on the forced swim test. Anyway, these female rats did have depression-like behavior, but in addition to that, they had diffuser overactivity. And these rats were given in 3 different times, duloxetine, which restores serotonin depletion and norepinephrine depletion, mirabegron, and sulfonisin, all well known. What we saw is, the author saw, when you gave those medication, in all 3 of the medications, the diffuser overactivity decreased. But only in the duloxetine rats, the depression-like behavior was improved as well. So the authors, Dr. Verbel, said that this might be a good medication to use in patients with depression and overactive bladder. There's only been one study who has used that. We use this in daily practice, but I'll come back to that later on. What about serotonin norepinephrine in the bladder, in the human bladder? And there are some small studies which is done that indicate that OAB symptoms improve with using of Cymbalta, so duloxetine, which restores the serotonin level. And this was compared to placebo. A third possible common pathway, in addition to the different neurotransmitters in the different brain areas, is stress. Stress is very important in anxiety and depression, but also in the bladder. Everybody knows that when you're stressed, when you're nervous, that you might have to go to the toilet more often, maybe before a presentation or anything. So what is known from animal models? There are some animal models in rats and in rodents which were exposed to repeated psychological stress. And this repeated psychological stress was a water avoidance protocol. And when they were exposed to that, the voiding frequency went up and the voided volume went down. When these rats got a CRF antagonist, the voiding pattern was normal again. And what is very interesting, that even when the stressor was gone, so 1 month after the stressor was gone, the bladder symptoms still remained. How is that in the bladder? In the bladder, this is an interesting study from patients, female patients and female volunteers, and they were exposed to a trial social stress test. During this stress test, before, during, and after, the cortisol, saliva cortisol measurement was taken, and also the bladder symptoms, in order to see what is the stress response to this 3 social stress test. But I'm going to explain you first what this 3 social stress test is. This is a test in which subjects unexpectedly hear that they need to give a presentation in front of an audience. And they get 5 minutes to prepare this presentation. And after they have prepared the presentation, they make notes, the notes are taken away, and then they have to give the presentation. The saliva cortisol response to this stress test is measured before, during, and after, and they saw different responses. As you can see here in the light line and the dotted line, that the stress response to this stress test was much higher in patients with overactive bladder. What else was seen, that these patients with this overactive bladder and acute stress, they got increased urgency. So patients with overactive bladder have greater physiologic and psychological stress reactivity. This is also a bit seen in the study of Lai, who compared patients with overactive bladder pain syndrome patients, and healthy controls. And the overactive bladder patients reported much higher psychological stress levels, and these were as controls, and these were as high as the IC patients. And there was a positive correlation between the perceived stress level, urinary incontinence, and the impact of the quality of life. Another large survey from Korean women with over 100,000 subjects showed that stress is an independent risk factor for overactive bladder. What else is important in overactive bladder and symptoms? That is perception, and perception can change. This study from Melville had 2 groups of patients, both with incontinence, and they had similar complaints, and one could measure that with avoiding diaries and questionnaires. Both groups had similar complaints, but patients with depression perceived their symptoms much worse. And perception depends, for example, on neuroticism. So that's personality with a tendency to see everything negative, to see everything gloomy. It's a link to one of the first articles I quoted, the Italian study from the post-corona time, where it was seen that patients with neuroticism, with a gloomy worldview, were much higher at risk to develop stress symptoms. But also perception of bladder symptoms, for example, also depends on neuroticism. But perception also depends on the history of negative life events, or for example, child abuse, somatization, so a difference. So what are we going to do with this knowledge? So we know now that there is a relationship between anxiety, depression, post-traumatic stress disorder, and bladder symptoms. We know that stress can aggravate symptoms. We know that stress can change our perception. But how are we going to do with that in our outpatients clinics? So what you can do is to use a questionnaire to examine the affective symptoms. There are numerous questionnaires, the HATS, the GPS, the SES, the TAXI, the PRIME. We use the HATS, the Hospital Anxiety Depression Scale. In addition to that, you can ask for affective complaints. How is your mood? How is your sleep? How is your appetite? Do you want to get up in the morning? Do you look forward to things you normally enjoy? So how is it about anxiety? Have you got fear of busy environments, which is not so much the case now in the corona time, but you also want to know about general stress levels, and maybe how do these stress levels influence your bladder? Some patients really can tell. It's also important to look at life events, former life events, but also recent life events, and maybe COVID-19 related life events, for example, loss of relative, financial implications, social isolation. You want to know how it is with all that kinds of things. The other things you want to know, you want to ask about bowel symptoms. And why do you want to ask for other things? Because we know that overactive bladder, anxiety, and depression is also related with other functional disorders. So fibromyalgia, IBS, bladder pain syndrome. And in our clinic, we often work together with a psychiatrist, and we look specifically for these kinds of symptoms. But also without a psychiatrist, you can look at bowel syndrome, heartburn, IBS, diarrhea, but also palpitations, hyperventilation, and sexual function disorders. And once you know a bit more about the stress levels, and you get a sort of feeling, a sense if these stress levels influence the bladder. And then you can focus not only on the bladder, but also on the stress levels. I'll come back to that a bit later. Because how is it with the treatment? What happens when we treat? When we treat the overactive bladder, and there are studies done, and there's used different treatment modalities, for example, medication, sacral neuromodulation, one could see that with improvement of the overactive bladder, also the affective symptoms improved. And the other way around, less studies, but has been some studies done with hypnosis, psychotherapy, mindfulness, and one could see that with the improvement of the affective symptoms, also the overactive bladder symptoms went down. Then another interesting study, it's a small study, but nevertheless, Baker used mindfulness to treat overactive bladder. There are two groups of patients, females. One group got mindfulness, one group got the control group got yoga. And the mindfulness group learned to see, to experience their symptoms with non-judgmental. So I've got a full bladder, period. Instead of labeling this with emotions and, for example, catastrophic or fear, or I've got a full bladder, I don't know where the toilet is. No, they learn to just experience the symptoms without judgment. And what was very interesting, that in the mindful group, their OAB symptoms reduced. And even after stop of the treatment, the symptoms were reduced. And I use this in my daily practice. I tell people to use mindfulness, for example, not only for the bladder, but just for general relaxation and lowering of the stress levels, because there are a lot of online courses or courses in the neighborhood which might be able to follow. That leads us to the take-home message. So COVID-19 could indirectly worsen OAB symptoms or possibly lead to new OAB in the future. And the combination of affective symptoms, psychological symptoms, and bladder symptoms is a complex mechanism in which brain area, serotonin, stress, and perception plays a role. And I think that you have to consider psychological complaints and have integrated evaluation and treatment. Thank you very much. Questions can be asked later. So now, Francois, you can start your presentation. Thank you.
Okay, so I will share with you my first slide. It's okay?
Yes.
Okay, so we'll talk about nocturia and lockdown, change in symptoms. I have no disclosure related to this talk. And just before starting, I would like to make things clear. In this talk, I will not talk about nocturia in COVID-19 infected patients for several reasons. The first one is because there is no data in the literature. And secondly, because it's definitely not a major issue in intensive care unit patients with indwelling catheters. And we don't really care about the volume voiding during nighttime in these patients. So during the outbreak of COVID-19 pandemic, all medical departments underwent a deep reorganization. Guidelines and priority flowchart have been published by scientific societies, and specialists were asked to prioritize their patients in order to reduce the non-necessary or the less necessary consultation and surgeries. For sure, nocturia is not a life-threatening condition on a short-term perspective, and we cannot compare it to malignancies or catheter-related complications needing real face-to-face consultation. But there are a lot of questions remaining and regarding the current situation. For example, what about the backlog due to the pandemic? And what if we constantly cancel and reschedule patients later? Another question would be how long this lockdown period will last? And what if there is a second wave? There is a high risk of accumulating waiting lists, and for this reason, here lays an important place for telemedicine. So in this talk, we'll have together a view on different perspectives on nocturia, not only from a urological point of view, but also from other angles. We'll evaluate together to which extent the lockdown and the work from home situation may have an impact on nocturia. Because when calling your patient, they may report some changes in their symptoms. So that can sound a bit surprising to you as a practitioner. And this presentation offers you the tools to understand what's going on, but also some advices to deal with it. So here is the outline of my presentation. I will first give you some background information on nocturia. Then we'll have together a look to some scenarios, some changing in the symptoms that patient may present. And then we'll have together a look to the thing that can be done. And I will give you some take-home messages. So I'd like to first set the scene, explain you what we mean by nocturia and why it's important to consider nocturia. So LUTS are classified into storage phase symptom, voiding phase symptoms, and the post-micturition symptoms. And you see that nocturia is a part of the first group. Nocturia is defined as the number of times urine is passed during the main sleep period, and this corresponds to the last update of the previous standardization documents. It's a frequent and bothersome condition. It's strongly related to the number of awakenings. You see here on the slide that the patient has 3 nocturia episodes, but it may be twice, it may be only 3, it may be 4, and sometimes even more. Problem with nocturia is that it decreases quality of life, and not only the quality of life of your patient, but also the quality of life of the partner, because when you wake up, you bother your wife, you bother your husband, and it may be a big problem. The thing also with quality of life is that it's not only about nights, but you also have an impact on daytime function, because if you wake up, you are tired during daytime and you express some fatigue. You also have an increase in mortality, and we know that patients with nocturia have an increased risk of falls and fractures, but also early death and cardiovascular diseases on a long-term perspective. So for all of these reasons, the management of nocturia is an important issue and a matter of public health. For a long time, nocturia received very little specific attention and was considered just one of a number of LUTS indicated overactive bladder, even if the principal cause is an increase in diuresis during nighttime. But this figure that you see here is probably a bit too simple, isn't it? And it's probably the view of the urologist. But when you talk with your colleague at the hospital, you realize that there are many medical disciplines in which nocturia is found. When you talk with the cardiologist, with the sleep specialist, with the gynecologist, many specialties around us have some patient with nocturia symptoms. So with the NOPIA, which is an international expert group on nocturia, and with the ICIRS, we designed this wheel that I will show you here, where we address the different causative factors of nocturia. So you see that it's not only about bladder, but there are several other disciplines which may play a role leading to nocturia. And I will explain you now these causative packages, all these blocks around nocturia. I will explain you how it's working, and it's quite important to understand to consider nocturia in a holistic way, but also to deal with nocturia correctly. So let's have a look to the first block. The first block is the orange one, so it's bladder. I'm pretty sure that you don't need any explanation for the bladder part. Nocturia may be due to a reduced bladder capacity, due to an overactive bladder, or to an incomplete bladder emptying with, for example, post-void residual. If we go to the nephrological package, so the second one, you know that the amount of urinary output is determined by the balance between fluid intake, fluid distribution, and fluid excretion. And fluid excretion consists of water diuresis and solute diuresis, with a major role for sodium. When you look to water diuresis it's stimulated by a low level of antidiuretic hormone, while sodium diuresis is stimulated by low level of renin-angiotensin aldosterone system and a high level of atrial natriuretic peptide. Let's move now to hormone. So when you think about changing in hormonal status, you think directly to menopause. We know that women with estrogen deprivation have high risk of storage disorders, but also a risk of change in diuresis rate through sodium and water excretion, water reabsorption. So the effect of the estrogen is not only about bladder, but also about diuresis. And when you talk about hormonal changes, it's also about diabetes. And we know that patients with diabetes have an extra osmotic diuresis because, for example, of glycosuria. Now, the sleep package, we know that patients who are bad sleepers may have some convenience void. What is convenient void is a patient that awakens for some reason not related to the bladder. So you're awake and then you just go to the bathroom because you are awake for another reason, for example, some noise in the room or in the streets. But we also know that patients with obstructive sleep apnea and patients with periodic limb movement syndrome and restless leg syndrome have more risk of nocturia and nocturnal polyuria. And for example, if we want to understand what's going on, here is the example of obstructive sleep apnea. Patients with closed airways have some inspiratory efforts leading to negative intrathoracic pressure with cardiac distension, a release of atrial natriuretic peptide, and sodium diuresis. Now, the cardiovascular block, if we consider the cardiovascular domain, there are many factors that will induce nocturia and nocturnal polyuria. It can be related to an increase in central vascular system in patients with lower limb venous insufficiency or congestive heart failure. And in these cases, the fluid retention leads to nocturia through a reduction of fluids when the patient is supine. It can also due to an increase of blood pressure during nighttime. You know that normally the blood pressure is supposed to decrease when sleeping. If we have a patient with a high blood pressure during nighttime, we have what we call non-dipping hypertension, and this leads to to a higher blood filtration and an increase in diuresis. And finally, the last block, intake. Of course, it's an important role about fluid intake. The more you drink, the more you're gonna need to go to the bathroom, but also the type of beverage and vegetables eaten. If you eat some vegetables with a lot of water in them, then it may be an issue for you, but also the number of calories eaten, because if you have a too high intake of osmol, it makes you thirsty and it makes you want to drink, and then of course it will increase your diuresis during daytime, but also during nighttime. So you see here that nocturia is a multifactorial condition, and not we started from a story only with bladder, but you see that other disciplines are involved, and in all of this discipline you have the concomitant medication, the pills and all the treatments that the patient may take for each of his or her disease may also have an impact on the nocturia symptoms. So now that we understand correctly nocturia from a multidisciplinary point of view, we can elaborate on different situations. And I would like to have a look with you on 3 different scenarios. The first scenario is a patient with nocturia and a stay-at-home situation, so the lockdown, and he has or she has a worsening of the symptoms. The second situation is a patient with nocturia, stay-at-home situation with an improvement of the symptoms. And the third scenario a patient with nocturia, lockdown situation, and the symptoms remain stable. So of course, this scenario will not be mentioned in my slides because this is the situation in which there is no change. So we'll only talk about the two first scenarios. For the first scenario, the patient has a worsening of the symptoms. This means that the number of awakenings increases or stay the same, but has more impact on the quality of life. So now that we understood how Nocturia is working, we can have a look to all these different diagnostic packages that we saw before, and we can try to understand what's going on. So here, we just heard before from Dr. Vrijens' talk that anxiety has an important role to play in bladder symptoms. So maybe because of this pandemic situation, the patient has more anxiety and more bladder symptoms. We know also that a lot of patients stay at home and they don't go to their GP anymore. They don't go to the pharmacy to take some medication. And there is a high risk of patient who is underdiagnosed and undertreated UTI. And that may also be the reason why they have some more symptoms of nocturia. We also know that a lot of patients are unable to get their regular medication because of some countries' policy to all minimal stocks. And also it can be an issue when the medication are coming from China. So we may also have some patients with uncontrolled diabetes or estrogen deprivation, which may bother the hormonal status and may have an impact on nocturia. Maybe if you are at home, just wondering how your business will go, with some complaints and some problem and some issues regarding your finance. For example, maybe you sleep worse, and then you wake up at night because you're always remaining with your bad ideas and all your problems. So the sleep quality may also play an important role. And then if you stay at home, another problem that patient may face, that you don't perform some physical activity. You stay in the sofa all day long watching TV, so you have more leg edema. If you don't take your prescription for your blood pressure, you may have an increase in blood pressure leading to nocturia as well. And finally, if we look to the intake box, if you are all day long next to the fridge, you are able to drink some more water, drink some more Coke, drink some more alcohol as well. And maybe it's easier. And we know that in strange and difficult times, people sometimes go into food. So maybe you will gain some weight and get obese, and obese patients have a higher intra-abdominal pressure, and this causes increase in filtration and an increase in diuresis. So these are some ideas to explore the fact that nocturia may be worse during the pandemic. Now another scenario, the scenario in which the patient has less symptoms, so less nocturia episodes, or it totally disappears. Another explanation could be that it remains with the same number of awakenings, but it has less impact on the quality of life. Because of course, if you wake up twice a night, but you don't need to go to work the day after, then it's less problematic, of course. So this situation is a good thing, actually. You don't want to change it. Your patient tells you that he has less problems, but at least it's interesting to try to understand what's going on. And that's what we're going to do right now. So again, I will show you this cornerstone figure with all the causative packages. And to start with the bladder, we know that patients with an overactive bladder staying at home have an easy access to the bathroom. So it may be also a reason why they feel better. If you stay at home and you don't have your boss bothering you all day long, maybe you will sleep better. And you will not wake up during nighttime thinking about all the things you have to do, and you will not have the convenient voidings that you used to have before. If you are at home, maybe while watching TV, you will lift up your legs, and you have less leg edema at the end of the day. And maybe if you stay at home all day long, you are able to adapt your fluid intake, because usually you were so busy at work during daytime that you were drinking your 1 liter bottle at the end of the day because your wife was going to kill you if not done. So now you have all day long and you are able to drink correctly at regular moments, and maybe you drink less coffee also. So that may explain the reason why Nocturia has improved. Now, what can be done, and what are the take-home messages? So you see that we started from like a decade ago, from a situation in which the urologists were the only one involved. And now we are in a multidisciplinary topic with a variety of factors that can influence a number of awakenings. So if you only think about bladder, you will miss a large part of the contributing factors. So the message is explore each causative factor. This does not mean that you will have to do a cardiovascular examination, but at least you ask your patient and you have to consider it. The bladder diary is really important in evaluation of nocturia and nocturnal polyuria, and that's quite easy to send by email and to receive it back by email as well. So if you explain your patient to do it, you are able to send them the paper and get an easy answer. You can also evaluate the fluid intake and the way people are eating. You have to ask about sleep quality and anxiety. We heard it from the first speech that anxiety may have an impact as well. You have to enhance leg elevation and using of compression stockings in order to reduce leg edema. And of course, you don't want that your patient have a disturbance of the different packages, and then you have to promote and you have to stimulate the observance of usual medications, and you have to send and you have to say to your patient that they have to see other specialists when it's necessary. We don't want to have patients with heart failure. We don't want to have patients with uncontrolled diabetes. So we have to tell them that when necessary, they have to go to other disciplines, even if it's a lockdown situation. And finally, don't forget to check the serum sodium if you prescribe some desmopressin in patients above 60 years old. Even if it's a lockdown situation, those patients need to have blood analysis with control of their serum sodium. So even if you perform some teleconsultation, keep a list of the patient that need to be controlled. Just to finish with this paper, which is the ICS consensus that we've written on the diagnosis and the treatment of nocturia. Thank you very much.
Thank you very much, Francois, for this interesting presentation. We've got some time for discussion. I would like to ask you, what's your opinion or your experience of the last few weeks? What is the effect of the pandemic on the nocturia? Do you think it improves, it worsens, or does it stay stable? What's your opinion so far?
Actually, I had these three scenarios that I talked about today. So I would say a third of each scenario was visible. And of course, you have a lot of patients with the same number of awakenings, so the situation remains stable. But as I told you, when you don't need to wake up to go to work, then you don't really mind about getting up during nighttime, even if it's a bothering situation. And as I told you, it's not only about the patient, but it's also about the people living around. So everything is possible. I had the three types of patients.
And do you see any difference with the ages? Because I think that maybe for patients who need to go to work, there is lots has changed during this pandemic. While elderly, they might not have to get up early at all. It doesn't matter if there is a containment or not. Do you see any difference between the age groups of the patients?
Then regarding the age, then you probably have some different types of causative packages involved. For sure, when you talk about an old lady, maybe it's more about leg edema, and when it's a young patient like 30 years old, getting up at night, it may be related to a lot of stress due to the situation and financial aspects. So everything is possible, and that's why this nice figure is easy to understand and easy to explore with your patient.
Yes, we had some questions through the ICS live stream, and one of the questions of Dr. Everard is, he states that we need nocturia research which integrates anxiety, depression, and overactive bladder, and nocturnal polyuria, and sleep. Are you up for that? Do you think we can think of a research project for that?
Yeah, that's good. That sounds great.
Well, I think it will be difficult to establish whether the symptoms are due to anxiety, depression, or due to sleep deprivation or things like that. What do you reckon?
I think you done some study regarding the anxiety and depression. So I think you have the good knowledge.
We have to combine that, I think. And there is another question from Dr. Goldman. He wanted to have to know what's the role of the diuretic in the late afternoon to help these patients. Do you promote taking a diuretic in the late afternoon? Or?
So we know that there is only good evidence for desmopressin and for CPAP when talking about treatment of nocturia. So only good evidence, so level 1A evidence for those treatments. The rest for furosemide, for example, is a moderate level of evidence. But we know from the pathophysiology of nocturia and nocturnal polyuria that it may be due to either water diuresis or sodium diuresis, and sometimes a combined mechanism. And of course, in patients with sodium diuresis related nocturnal polyuria, giving some furosemide at the late afternoon, so we recommend usually to give it 6 hours before going to bed, may be an interesting approach for those patients with nocturnal polyuria related to sodium diuresis.
Okay, yes, thank you.
I think I have also some questions for you. So there is a question from Howard Goldman asking, do you think there is an independent role of child/sexual abuse on OAB, or is this just due to the overall psychological trauma?
Yeah, that's a very interesting question. So is sexual abuse an independent risk factor for overactive bladder later, or is it due because of that's an early life adversary? I don't think that it's that there has been many studies done to really establish the two of them, because there is a lot of overlap. There are a lot of patients across over who had abuse, who also had bullying, for example. So it's very difficult to put it aside. But we know that early lifehood adversaries has got changes in brain structures, which makes them more likely to get depressed. Also, low-grade infection can play a role with crosstalk and a different microbiome, which makes them all more vulnerable. And so there is a bit of a shift in the balance between vulnerability and resilience. And it all plays a role, and it definitely is the case that people or youngsters who have had negative life events early on, that they are more prone to develop overactive bladder later, or bladder pain syndrome. Yeah.
I was wondering, you told in your presentation that in some cases you see the patients with both urologists and psychiatrists.
Yes.
Is that true? Yeah. And how do you decide? I mean, you cannot see all patients together.
No, we have to say we are a tertiary referral center for functional urology. So we see a lot of second, third, fourth opinion. So probably we see an even more select patient group. But in general, with every patient, where is a primary referral from the general practitioner or second or third opinion, we all do a HATS. So everybody gets a hospital anxiety and depression scale to fill out. And the questions that I stated in my presentation, we ask them always as a routine measurements. And sometimes you see the patients, you've got them as well, I think, that you should see patients and there is more to it than only the bladder problems. Mm-hmm. And then when you sense that, then we talk with them, then that we want to see them together with the psychiatrist. And in the beginning, it's sometimes hard to convince the patients. But when you say, okay, you've had one or two medication or one or two therapies for the bladder and it doesn't work, we have to look higher in order to look at the neurological regulation and also the psychological part of it. Because voiding is in the brain, isn't it? We have to decide when we have to go to the toilet, and a lot is conscious and a lot is unconscious. So yes, it's very interesting. We're privileged to have a good psychiatrist at the team. Do you use, for example, an anxiety scale or something like that for your patients?
No, I do not.
You do not. No. So I think we've got time for one more question. And you explained us in your presentation the role of obstructive sleep apnea. But how does the restless leg syndrome work with?
We know restless leg is associated with dopamine disorders, and we know that dopamine has induced some changes in diuresis, but also in bladder function. So it's related. It's a dopamine related disorder.
Okay, so I've got one more question, the practical question from Dr. Bates, who says, okay, the pandemic is a bit over. We are starting to see patients in a regular way, although a lot of patients can only be seen when it's urgent or extremely important. So, for example, with ulceration, dermatitis, pressure ulcers, in incontinence. So when all elderly people suffer from nocturia, and they have got many frequent visits to the bathroom with risk of falling. Do you consider that as an indication to see the patient in the room instead of virtual contact?
The way we are dealing with the situation right now is that we are trying to see to stop the lockdown and to see more patients. So I hope that we are able to see more and more patients. Then every specialist and every practitioner is able to evaluate if the patient needs to be seen or not. Of course, if your patients suffer high enuresis or high incontinence, then maybe you are more able to you want to help him and you want to see him. So you can always try to first evaluate by teleconsultation and then see if it's necessary to see him or her, and I hope that we won't stay for a too long period in such a pandemic time, and that we'll be able to go back to normal consultations.
Yes, let's hope to go back to normal, and for a lot of people, very important, I think. Do you have got one more question to ask or not?
No, I have nothing more.
No. I want to thank you, Dr. Hervé, for your nice presentation. I want to thank the ICS for giving the opportunity, and I want to say to everybody, don't forget to look at ics.org/live for other live streams later this week. You can also watch them back later time. Thank you very much.
Thank you.
Bye-bye.